And I'm now going to introduce Dr. Erika Sullivan, who will give us the final talk of our conference. Thank you.
So my understanding is that you guys have been sitting for a long time. So if you would like, I invite you to stand up and stretch out a little bit. We often forget to do this at medical conferences, even though we encourage our patients all the time, get up, use a standing desk, all of that. So again, my name is Dr. Erika Sullivan. Actually, could you make it so that the presenter view is down here? Is that possible? Okay, well, if not, I can muddle through. But my name is Dr. Erika Sullivan. I use she, her pronouns, and I'm going to be talking to you about gender-affirming care. In terms of disclosures, I have no relevant financial disclosures, but we will be discussing the off-label use of medications with other FDA-approved indications. I'm also the founder and medical director of the Mountain West Transforming Care Conference. I am the founder and president of the Gender-Affirming Primary Care Residency Research Collaborative, and I am a member and frequent contributor to the medical conferences put on by the World Professional Association of Transgender Health, the Global Education Initiative, or WPATH-GEI. In terms of our objectives today, we're going to be talking about how clinicians can create a safe space for LGBTQI+ identified patients within a clinical setting. We'll understand the factors which contribute to the gender and sexual minority stress model. We'll understand a general approach to diagnosing and treating individuals with gender dysphoria or gender incongruence. And we'll understand the very basics and principles of both estradiol and testosterone-based gender-affirming hormone therapy. I'm going to be using a lot of citations, and I have put QR codes for many of those things, so if you're so inclined and find that you'd like to go back to the primary resource, please go ahead and scan the QR code. I also like to always start these talks with a bit of positionality. And so my position is that I am a white, heteronormative-ish, cisgender female living in Utah. And I do not identify as someone who is gender diverse or of transgender experience. I also recognize that this may be a topic that you do not feel like you have much familiarity with or feel is very relevant to your clinical practice. And you may think that we don't really have that much in common. But I would argue that we actually have quite a bit in common, which is that we both went into medical school to help people. So you may think that you went into medical school to help people with a new diagnosis of diabetes, or to help someone navigate having a child with constipation or an ear infection, or to help people who want to change various aspects of their body, either because they don't like the panis that they have after having 2 children, or they're getting reconstruction after having breast cancer, or they've been recently diagnosed with colon cancer. And I'd like to point out that for all of these things, this is something that these patients have. It is not necessarily something that they are. Their experience as a human is not necessarily shaped through the condition of having diabetes or having constipation. Whereas for people who are transgender, this very much is something that they are. It is a part of who they are. It is part of their identity. And that really colors the way that they experience the world and the way that the world experiences them. That can also have an impact on how they sort of perceive and relate to the world and how they relate to themselves as being transgender. And this can be by opening various different doors in order for them to explore this. So some people often start with just education. They go online. They look up, are there other people who are feeling this? Are there other people who have experienced what I think I'm experiencing? They may start exploring how they express themselves, how they express their gender identity. They may do that in different environments. They may express one way at home and another way amongst friends and another way at work. They may, in fact, come out to their friends and family, or as I like to think of this, they let people into who they are, into who their real self is. Some people will often engage in therapy, particularly with a mental health provider who has experience in working with people with gender dysphoria. Some people may explore using hormones to achieve some physiologic changes that they're hoping for, and some people engage in surgery, and yet other people engage in other resources that are offered in the medical setting that can help affirm their gender. The important thing to recognize, though, is that there is no right or wrong way to be trans or to be gender diverse or to be who you are, and that each individual person is going to have their own set of goals and expectations, and really your job as the medical provider is to just tap into what it is that they're looking for and to help them achieve those goals, just like you would really with any other condition. When thinking about gender dysphoria, I think it can be helpful to sort of root back into some definitions. So the DSM-5 does actually have a definition for gender dysphoria. And so they state that the DSM defines gender dysphoria in adolescents and adults as a marked incongruence between one's experienced or expressed gender and their assigned gender, lasting at least 6 months and as manifested by at least 2 of the following. So a marked incongruence between one's experienced or expressed gender and primary and/or secondary sex characteristics, a strong desire to be rid of one's primary and/or secondary sex characteristics because of a marked incongruence with one's experienced or expressed gender or some other gender, a strong desire for the primary and/or secondary sex characteristics of the other gender, a strong desire to be the other gender or some alternative gender, a strong desire to be treated as the other gender or some alternative gender different from one's assigned gender, and a strong conviction that one has the typical feelings and reactions of the other gender or, again, some alternative gender. And in order to meet the criteria for the diagnosis, the condition must be associated with clinically significant distress or impairment, social impairment, occupational, or other important means of functioning. So part of the problem with this definition is it's really rooted in this idea that there's an impairment. So we talk about gender dysphoria and not, in fact, about gender euphoria. So that's part of the problem with the definition. The other is that it's very clearly rooted in this binary, right? The other gender. And when we use words like other, it very much means this or that, this door or that door. And that can be a real problem because for many people, they do not experience gender as one thing or another. But going back to this idea of sort of why we all went into medical school and that it was for us to help people, I think fundamentally what we need to take away from the diagnosis or the definition of gender dysphoria is that this is happening to people. They are people who have hopes and dreams. They have jobs and hobbies and passions. They are brothers and sisters and husbands and wives and mothers and fathers and parents and sons and daughters and children. They are people. And we promised to help them. In fact, we took an oath, a sacred one, to first do no harm. And in fact, these people are being actively harmed. To be transgender in America right now means that you may experience harm from every dimension in your life. So that can happen at home, it can happen as a result of legislative action, it can happen in the bathroom, it can happen in religious institutions, and it absolutely can happen within a healthcare setting. On the home front, many transgender individuals experience rejection from their family members. When this rejection and abandonment comes from the people who are supposed to love them unconditionally, it has particularly insidious impacts on their mental health and is associated with higher rates of suicide attempts, illicit drug use, and poor health outcomes. In contrast to the discrimination that's faced by other minority groups, in many instances, those who identify as LGBTQIA+, and particularly those who are trans, do not possess a shared stigmatized identity with their immediate family members. And so as a result, family members of trans-identified people are not able to provide what we think of as primary group member support, which can act as a buffer and/or offer a path that has helped that individual overcome similar stigmatization. In one study, using data from the National Transgender Discrimination Survey analysis of 3,548 self-identified transgender individuals, it showed that 42% of respondents had attempted suicide, and 26% had misused drugs or alcohol to cope with the discrimination they experienced. After controlling for other variables, the researchers found that moderate family rejection doubled the odds of attempted suicide, and high levels of family rejection were associated with an almost 3.5 times the odds of attempted suicide. It is theorized that family rejection may have negative health outcomes for several reasons. One, the rejection from the people who are supposed to love and care for you unconditionally is in and of itself a stressor. And this stressor can have negative impacts on mental health, economic security, and may result in health behaviors that have downstream sequelae. And two, family rejection deprives trans-identified individuals of the protective buffering that usually comes from the social support needed by children to thrive in adolescence and into adulthood. Our government is also actively causing harm, and every year a new level of harm is unveiled. The ACLU is currently tracking 484 anti-trans or LGBTQ bills in the United States. And in fact, there were so many LGBT laws proposed in Utah this year that I had to screenshot this twice. Not all of them passed, but 2024 was not the first time that Utah legislature went after trans people. In 2022, a law was passed which would determine if transgender girls can compete in school sports. And in 2023, Governor Cox signed the bill that banned most gender-affirming care for minors. The tsunami of anti-trans legislation has had significant impacts on LGBTQ youth across the nation. In the 2023 U.S. National Survey on the Mental Health of LGBTQ Young People that was conducted by the Trevor Project, over 28,000 LGBTQ youth were surveyed, and a shockingly high number, 1 in 3, reported that their mental health was poor due to anti-LGBTQ policies and legislation. 2 in 3 LGBT youth reported that hearing about potential state or local laws that banned people from even discussing LGBTQ people at school made their mental health worse. There's also discrimination that's happening and being perpetrated against trans people as it relates to the bathroom. So when you went to the bathroom today, you probably didn't hesitate for a moment. You approached the room with a triangle dress or the one without, as you always do, sort of contemplating your never-ending to-do list and perhaps regretting that second cup of coffee. But depending on where you live, if you identify as transgender, your ability to empty your bladder in a public restroom can in some places result in criminal prosecution. To be trans in America and in Utah right now robs you of this luxury. You are constantly aware of your transness because you have to be, because you are forced to be, because your safety and self-preservation demand it. Discrimination can also be experienced in religious settings. So various forms of religiosity have been linked to trans prejudice, including church attendance, interpreting the Bible literally, and religious fundamentalism. Trans people can also experience bullying to an extent that is causing significant morbidity and mortality. This bullying has gotten so bad that even kids who are not trans are being bullied and being targeted. And for those who are trans, this bullying can often lead to tragic outcomes. All members of the LGBT community have increased risks of mental illness, including anxiety, depression, deliberate self-harm, risky sexual behavior, suicide, and homelessness. Each of the LGBT populations has a much higher average rate of substance use and abuse, including tobacco, alcohol, and other drugs. And it's thought that these will start at a younger age, and that youth that identify as sexual and gender minorities have 3 times the odds of substance use, and that these conditions are more likely to persist into adulthood. When we think about suicide, a lot of the data comes from the Youth Risk Behavioral Survey that's administered in high school every year. So data from the 2019 survey showed that for lesbian, gay, and bisexual high school students, they were more likely to report a suicide attempt during the past year. So people who were not sure about their sexuality were slightly 2.7 times more likely to have had an attempt, and people who are identified as lesbian, gay, or bisexual were 3.8 times as likely. We also have data related to suicide that is specific to Utah. And as you can see by this graph, Utah is consistently above the national average for rates of successful suicide. It is thought that a lot of this has to do with access to firearms, because firearms are particularly lethal in terms of being able to be successful at suicide. With some of the Utah data is broken down amongst youth and then sort of divvied up by their sexual orientation, you can see that the risk of ideation of suicide is highest amongst bisexual people, with 52.3% reporting ideation, and gay and lesbians is slightly lower at 47%. The lifetime suicide attempt rate for transgender identified people ranges from 30 to 80%, and that sort of depends on the study and the location. And just to put that in context, the incidence of attempted suicide in the general population is under 1%. Trans populations also experience extremely high rates of gender-based violence, with estimates ranging from 7 to 89% in the United States. And particularly in trans women of color, who have the highest rates of dying by violence, and this occurs at a truly alarming rate. Finally, harm is also purposefully and inadvertently perpetrated by providers within healthcare. This can be directly experienced by a trans person who's being denied care, or indirectly by being subject to the shortage of healthcare providers who are knowledgeable about LGBTQ health issues and capable of delivering culturally competent care. Lesbians and bisexual women are less likely to receive preventative services for cancer because of delays and avoidance of medical care, and are more likely to be overweight or obese and to smoke. Gay and bisexual men are at higher risk of HIV and other sexually transmitted infections, in addition to prostate, anal, testicular, and colon cancer, due to challenges in receiving culturally sensitive care. Transgender persons are even less likely than gay men or lesbians to have insurance, and they have higher rates of STIs, HIV, poverty, unemployment, mental illness, and suicide, and are at the highest risk among all LGBT-identified people of violent victimization. So the most significant health disparity among LGBT people arises from the avoidance of routine health care and the dissatisfaction with the health care they do receive as a result of a perceived lack of sensitivity of healthcare personnel and a fear of the consequences of revealing their sexual identity. Lambda Legal often refers to this as sort of a catch-22, because patients often worry that disclosing their sexual identity or sexual orientation will lead to discrimination, but without disclosing that, they may be getting inadequate care. So this leads me to this theory that has arisen called the sexual and gender minority stress model, which I think sort of explains all of these factors that I've just elucidated. So the author of the sexual and gender minority stress model offers a conceptual framework for understanding minority stress, explaining that stigma, prejudice, and discrimination create a hostile and stressful social environment that causes mental health problems. The model describes stress processes, including the experience of prejudiced events, expectations of rejection, hiding and concealing, internalized homophobia, and ameliorative coping processes. So how can you help as a provider? Well, one thing that you can do is you can perhaps expand your definition of what gender is. Now, it may be true for you that there's two genders, and that's okay. For you, that can be what the answer is. But it's also possible that for other people, other genders exist, and knowing what those other genders are and allowing your patients to exist in that space can be very powerful. I also like for providers to understand what I refer to as the Venn diagram of evil, meaning that those people who experience gender and sexual minority stress may also be experiencing socio and economic stress, or racial stress, or toxic stress from growing up in unsafe environments. And it's important when we're seeing patients that we're recognizing that that trauma may have occurred, and we are looking and providing care through a trauma-based lens. It's also important to recognize that patients may have had none of that, that the person in front of you may have grown up in sort of idyllic conditions, and just because these conditions and rates of things can be true, it does not mean that they are true. It's important that we're creating safe spaces for our patients so that they know when they're coming into our office that this is going to be a place where they can be their authentic self and that you're going to see them and recognize them for that. One way that you can do that is by asking for patients' pronouns. Now, the challenge with this in a clinical setting is that we often only do this when we look at a patient and we think, I bet you don't use pronouns that I think that you probably use, so I'm going to ask you what your pronouns are. The problem is that you're making an assumption about that patient, and that assumption can be wrong. And so I think the better practice is to not rely on your assumption and really just to ask everybody what their pronouns are, because it can really create a transformative experience for someone who's never felt like they've been seen or heard in a clinical setting. And for other people, they might be alienated by doing that, but the only way that we're going to move the dial on this is if it just becomes a part of clinical practice. Again, so thinking about questioning all of your assumptions. And I recognize that in medicine, we make a lot of sort of quick judgments. We have to. But I think within this space, it's important that we don't allow those assumptions to color the care that we're providing, or at least we recognize assumptions when they occur and make sure that we're not sort of clinically acting upon those assumptions. So one assumption that comes up a lot, especially when you look at somebody, is assuming what sort of organs that they have. So this is particularly important in emergent settings where someone might be complaining of abdominal pain, and if that person has, facial hair and sort of is presenting as male, you may not think that this could be an ectopic pregnancy, but it absolutely could, because you're assuming that this person doesn't have a uterus. So one thing that is important to do is to perform an organ inventory. So I often do this annually for all of my patients because, of course, everyone's organs can change, right? And so the way that I ask it is I say, in terms of the organs that you have or that you think that you have, does that include breasts, cervix, ovaries, uterus, and vagina? And I go through it and change it every year. It's also important for us to screen everyone for depression and for suicide risk. And if there's one thing that you take away from my talk, I hope it's this, which is that you can have a meaningful impact on preventing suicide and talking with patients about limiting their access to lethal means. So CALM training is something that is freely available online, and really is excellent CME. It doesn't take very long. It's about 20 minutes. And particularly because suicide is so high here in Utah, it's really relevant for every provider. I think as a primary care provider, one of the things that really bothers me is PHQ-2s can be asked in any clinical setting, but if the PHQ-2 turns into a PHQ-9, and then that last question of, do you feel suicidal? And then the rheumatologist or cardiologist is like, oh, gee, you should go back and see your primary care provider because you're suicidal. Like, as a provider, you have to recognize that you are going to have people who are actively suicidal, and really that just sort of jumps to the top of the queue in terms of what needs to be managed today. The other thing I think it's important to recognize is that people can have both protective factors that limit their likelihood of committing suicide and have risk factors. So asking the patients about family accepted and their connectedness and their sense of safety, access to competent mental health care. And then on the risk factor side, thinking about what sort of mental health problems are underlying this suicide risk. Is there alcohol or drug use that might be contributing to this picture? Are these people experiencing prejudice or discrimination in a particular environment? And then social isolation. I cannot stress enough what a risk factor social isolation is in people who attempt suicide. So you can ask about community support, friend support, family support, and particularly here in Utah, again, where many trans-identified people do experience alienation from their family members, the found family can be a profound protective factor. And so querying your patients about whether or not they have social support and allowing them to sort of think of tapping into that social support as a lifeline if things are moving in a bad direction. So going back and thinking sort of larger and broadly about how do we create safe spaces for folks within the healthcare institution, I think one of the ways that we can do this is by reputation. So I'm proud to be a clinician at the University of Utah, where we are hoping at one point to become a center of excellence for transgender care. Every year we march in the Pride Parade, and every year during Pride, the U sort of identifies the Pride Month and sort of shows their colors, as it were. But it's important to recognize that all of those things are great, but at the same time, as we said, people who are trans-identified or queer-identified That is something that they are. It is not something that they turn on or off. It happens all the time, which means that every member of our healthcare team really needs to be trained on how to provide all patients and interact with all patients with dignity and respect. So we have to make sure that the people at the front desk and the people at the call center are all receiving culturally competent education. So there's a lot of resources actually that are available for training staff on how to care for people who are LGBT identified. One particular resource that I'll point out is through the National LGBTQIA+ Health Education Center, which is a program of the Fenway Institute, has absolutely fantastic resources that you can freely provide for staff members to help with this training. Another resource that's unfortunately particularly salient in Utah right now is the Refuge app. The app actually isn't working right now, but the website is still working. And what this website does is it directs people to gender-neutral or gender-safe bathrooms all over the world. It's sort of self-reported, so people will just put in the place or location of a bathroom that is safe, and it's becoming increasingly more important where bathroom laws are in effect, so people essentially know where there's a safe place for them to empty their bladder. Another fantastic resource is through Kalen Lord. So this is a federally qualified health center in New York that serves a predominantly LGBTQ+ population, and it has lots of great resources about things that you may have very limited experience, binding, tucking, hormones, things like that. So using these resources and making sure patients are aware of them can be really helpful. And then finally, 3 things that I think all of us can do is that we can be curious and not judgmental. We can be generous with our time. And you can be kind whenever possible, and it is always possible. So we'll take the last actually 10, 15 minutes or so and undergo the Sisyphusian task of describing gender-affirming care in about 10 minutes. A lot of this information comes from the WPATH, or the World Professional Association of Transgender Health, SOC 8, much of it from 2 particular chapters, Chapter 5, the assessment, and Chapter 12, hormone therapy. And understanding this graphic is really going to help you understand gender-affirming hormone therapy. So the hypothalamus secretes gonadotropin-releasing hormone. This acts upon the anterior pituitary, which then secretes LH and FSH. LH and FSH then act upon the gonads, which then secrete the sex hormones, so estradiol and progesterone and testosterone. Those sex hormones then have a negative feedback inhibitory effect at both the anterior pituitary and the hypothalamus. So keep this sort of diagram in mind as we go through and talk about hormone therapy. So in our clinic, we think about diagnosing gender dysphoria as occurring sort of over a multi-day approach. So we don't do what are called same-day starts. At the first visit, we really elicit from patients what their story is, or what I call their gender journey. So I ask them about when they first sort of felt different or had the experience of saying, this gender that I'm told that I am is not the gender that I'm experiencing. If it happened at a very young age, I asked them about what the experience of going through puberty was like as their body was changing. How did that affect them? If they didn't have the words or nomenclature at the time to describe it, how did they act upon it, or did they not act upon it? If they did act upon it and sort of let people into that experience, what was that like? What sort of support did they have? If it happened or they thought about it later in life, and again, oftentimes they retroactively sort of think, no, I knew this about myself at a young age, but I just didn't know how to express it. I wasn't in a place within my family dynamic where I could express it. How have they sort of experienced that, reacted to that, engaged with that? We also then sort of assess to make sure they meet the criteria for gender dysphoria or incongruence. We ask them about other medical or mental health conditions and whether or not they're reasonably well controlled. We make sure they have the capacity to give informed consent, and then of course they have to be 18 years of age or older. At the end of that first visit, I will then provide patients with an informed consent document. These documents are they are binary because it's either testosterone-based therapy or estrogen-based therapy, and each of them is about 8 pages long, going through pros and cons and risks and benefits of this therapy. I do not cover this at the first visit, oftentimes because we just don't have time. We've spent about 40 minutes taking this history, and I really want them to review this document. I want them to circle it. I want them to highlight it. I want them to have questions. So when they come for the follow-up appointment, we can have a very thorough discussion about pros, cons, and risk benefits. We'll also have a discussion about how the process of hormone therapy works in our clinic. So I'm at an academic medical center, so I have a lot of learners that will often be with me. We also talk about sort of what the visit structure is going to look like over the next year, over the next 5 years, the need for routine labs, et cetera. We also take a comprehensive sexual health history. The model that we use is formulated called the 10 Ps. So we ask about any preferences that they might have in terms of nomenclature that they use for their body parts or for sexual activities that they engage in. Don't typically ask pronouns during sexual history. As I said, I sort of start that at the beginning, but it starts with P, so we include it in the model. We ask about the partners that they have. What are the gender identity or sex organs that their partners have? What sort of practices do they engage in vis-a-vis sex? Do they have a past history of STIs? How do they protect themselves from STIs? I make sure that they're aware what HIV PrEP is, and we discuss whether or not their sexual practices might put them at risk for HIV acquisition, and therefore whether or not they'd be a good candidate for PrEP. I ask them about their pregnancy plans, and then in certain circumstances, I'll ask about sexual pleasure and partner violence. At the second visit is when we go over that informed consent document. My practice is to go over it line by line by line. I want to make sure that they understand what they're getting themselves into, also so that I can understand what their goals and hopes and dreams are, and to make sure that this pathway that we're sort of embarking on together is going to help them achieve those hopes and dreams. So thinking about those goals and timelines, I think one thing that's really important is that it's individualized for each person. It used to be that for providers, there was this idea that you either wanted the Dolly Parton or you wanted the Burt Reynolds. When I say that to patients, I often have to change the name of Burt Reynolds because no one knows who that is anymore, so I'm going to have to think of a very hyper-masculine younger person that my patients will know who that is. But that's really not the case as much anymore. And it's as providers who've been doing this care for quite some time, I think we've really had to move away from this binary idea of what people are wanting. So when I'm talking with people about their goals, I want to sort of stress several things. So for testosterone-based gender-affirming hormone therapy, or TGOT, I think about what is reversible and what is irreversible, and what has some degree of variability. So reversible things are like skin oiliness and acne, vaginal atrophy, and the changes in muscle mass and strength. Irreversible things are things like the changes to the voice, facial and body hair or growth, and clitoral enlargement. Sometimes you can think of these in terms of desired effects and undesired effects, but I think it's important that you're not laying on the patient that this is what you desire. Rather, you're eliciting from the patient what are the effects that you desire, and of this list of things that I said might happen, are any of these things that you don't want to have happen? Because I do have patients who say, you know, I really want my voice to be deeper, but I do not want to have facial hair. Or I would very much like to have a more androgynous look, but I'm not very interested in growing breasts. And so again, understanding what patients' desires are, and then having a very frank conversation with them about whether or not using hormones is going to be a good way of achieving those desires. Because I think sometimes people think that they can just pick and choose which changes will happen. And as we all know, because we all underwent puberty, that's not how it works, right? Secondary sex characteristics sort of happen, and it's not an a la carte menu. And again, thinking about sort of undesired effects, I don't know of very many people who are excited about getting acne or losing scalp hair, but again, talking about that and making sure they're aware that this can happen. It's also important that we have a conversation about the timeline over which these changes will occur. So some of the changes occur quite quickly. So the cessation of menses will generally occur within the first 3 to 6 months. And the vocal changes can actually happen pretty quickly. One of the changes that does not happen very quickly is hair growth, particularly hair growth on the face. And I think, again, if any of you have had kids or you're a pediatrician and you've watched adolescents go through puberty, kind of thank goodness that it doesn't happen overnight, right? Because it could be quite alarming. So I think the thing I like to point out to trans people is I know that you've been wanting these changes to happen for a really, really, really long time, but unfortunately we're going to have to be pretty patient because giving you more and more and more testosterone is not going to necessarily make that hair grow on your face any faster. When we think about the effects and expected time course of estrogen-based hormone therapy, so again, this would be used in people who are assigned male at birth, again, we think about what's reversible and what's irreversible. So the irreversible change really is the growth of breast tissue. Reversible changes have more to do with softening of skin and thinning and slowing of terminal hair growth, and then changes in the muscle mass. The variable changes a lot have to do with erectile function and sperm production. And that's an area of research that's sort of really hot right now because, of course, the questions of fertility are, of course, very important in this population. Some really exciting research that's happening in that space. Again, thinking about sort of desired effects and undesired effects. So for some people, breast development is desired, but again, for some people, it is not. So eliciting that, thinking about softer skin or thinner, slower hair growth, and then thinking about some of the undesired effects, mood changes, weight gain, and then the erectile dysfunction or decreased libido. Although again, for some people, this can actually be a real boon because they do not like the sexual function that they're currently experiencing and in fact find erections to be very dysphoric. Again, thinking about the time course, I think the main thing that trans feminine folks find frustrating is the slow rate at which breast growth occurs. This probably does take about 2 years before it's fully realized. Sometimes people can have breast growth for even longer. But again, talking with patients, showing them things like this where we're really having a cogent discussion about what's the timeline over which this is happening so that they have that expectation in mind is really important and an important part of that second visit. We also end up having a large discussion about risks and benefits. So the impact of hormones on fertility does take a lot of our time. And I really explain this to patients as a double-edged sword. So on the one hand, hormones can decrease sperm and egg quality and production and can lead to decreased fertility. On the other hand, it is possible to get pregnant or to get someone else pregnant while you are taking hormones. And so both of these things are true and sort of need to be held in space at the same time. So thinking about that, you want to sort of make sure that the patient has an awareness of the impact of hormones on fertility. You want to have a conversation with them about if they've ever considered how, if, and when they want to start a family. And then if they are in a sexual relationship where a sperm could meet an egg, you want to have a conversation with them about what their contraception plan is. Because the hormones can be, especially testosterone in assigned females at birth, can be detrimental to the fetus. So that fertility discussion, again, I'm belaboring it because I do think it's very important. You want to discuss the effects of hormones on eggs and sperm and that hormones can impact future fertility. You want to discuss that it is still possible to get pregnant or to get someone pregnant while taking hormones. You want to discuss options for fertility preservation, and if possible, this should be done before starting hormones, although again, area of really active research, it may be possible down the road to retrieve eggs and sperm. The other sort of risk that it's important to talk about is venous thromboembolism and cardiovascular risks. So this table is taken from the WPATH SOC8, and it really identifies sort of 2 key areas that I'm going to go over. So for EGOT, or estrogen-based hormone therapy, we think about the risk of VTE and cardiovascular disease. And then with TGOT, the sort of main risk is polycythemia, erythrocytosis, and cardiovascular disease. So the risk of VTE in trans feminine people, so this is people assigned male at birth taking estrogen, there have been a couple of cohort studies that have looked at this by Noda and Gedahune. And what they found, and both of them found this, is that there is a relative risk increase compared to both cis men and cis women of VTE. For myocardial infarction, the picture is a little bit mixed. So 3 studies have looked at this, and they have not found an increase compared to cis men, but they have found an increase compared to cis women. And then for ischemic stroke in trans feminine, again, a bit of a mixed bag. So Noda reported that it was higher, again, compared to both cis men and cis women, but Gedahune only noticed that it was elevated against cis women. So VTE risk in transmasculine people, so this is people assigned female at birth and taking testosterone gender-affirming hormone therapy, has not been associated risk in these people compared to cis men or cis women. With myocardial infarction, again, a bit of a mixed bag. So some of the studies have shown an increase against cis women, and only one study showed an increase compared to cis men. And then the risk of ischemic stroke in transmasculine folks, again, mixed picture. Noda noticed an elevated risk compared to cis women, but not cis men, and this was not observed by Gedahune. A couple of key points related to all of these things is that large cohort studies are lacking. The existing data suggests that trans feminine individuals, so assigned male at birth, taking estrogen, do have an increased risk of myocardial infarction and ischemic stroke compared to both cis men and cis women, and that transmasculine individuals, so assigned female at birth and taking testosterone, may experience an increased risk of myocardial infarction and stroke compared with cis women, but that this is similar to what is observed in cis men. But one thing I really like for us to sort of focus on is this study that was actually done by De Block in 2021. So this is a Dutch cohort so again, it's not here in the United States, it's in the Netherlands, and they've been providing gender-affirming care for about 5 decades. And so this study reported the mortality trends over 5 decades in adult transgender people receiving hormone treatment. And this observational study showed an increased mortality risk in transgender people who were using hormone therapy, regardless of the treatment type, and that this increased mortality risk did not decrease over time. So as you can see in the panel on the left, this is transgender women, and they have higher mortality compared to both cis men and cis women. And transgender men on the right, this signal is not quite as high, but again, higher mortality compared to both cis men and cis women. But when you look at what these people died from, many of these things were not thought to be related to hormone therapy. So people, yes, died of cardiovascular disease, but they died from lung cancer, from smoking, because of what I've mentioned before, that there's higher rates of smoking in this population. They died from HIV, because there's higher rates of STIs in this population. And they died by suicide, because this population experiences higher burden of mental health outcomes. So yes, there can be risks associated with using hormones, but there's risks with not using hormones. And so I think this is really well illustrated, although in a population that's different from trans care, by what's called the Turnaway study. So if you're not familiar with the Turnaway study, here's the QR code for it. It's a fantastic read. And really the point is yes, there's a risk of doing something, but there is also a risk of doing nothing. And many of us who provide gender-affirming care, we think of this as harm reduction, that by providing this care, we are helping to alleviate some of this downstream sequela that this population experiences. So thinking about baseline laboratory monitoring, we'll start with testosterone-based therapy. Everybody needs a CBC. Some people will need a CMP, lipids, A1C, STI, what I call PrEP labs, or a urine HCG. But those would be because they have other indications besides TGOT. So I would get a urine HCG, for example, on anyone who is having sexual relations and someone who produces sperm, but if that person reports they've never had sex with someone who produces sperm, there is really no reason to get an HCG. In our clinic, we use an order panel. I know you can't appreciate this because it's too small, but because we work with residents all the time and they get orders wrong all the time, we found that creating an order panel just made it really easy for people to pick the right labs and to do so consistently every single time. In terms of baseline labs for estrogen-based therapy, everybody needs a BMP, and that's because we only use spironolactone as the anti-androgen, which we'll talk about in a second. And then some people need, again, CMP, lipids, A1C, STI, and PrEP labs, but it's because they have indications other than estrogen therapy. And again, this is our estradiol-based lab order panel. When we think about ongoing laboratory monitoring, there's a couple of important concepts that I'd like to illustrate. So hormone labs are generally needed to monitor for super therapeutic levels. It's not so much to get into the nitty-gritty of being exactly in the desired range, although your patients absolutely are going to hound you about that. And it's really important to understand hormone pharmacokinetics in order to help you interpret lab results. In that in EGOT, or feminizing hormone therapy, testosterone suppression, so getting that endogenous testosterone low, is the most important thing, and more important than getting the estradiol in the desired range. And that it's really important not to get too hung up on keeping the labs in the normal ranges, because your patients really will perseverate on this, and so it's helpful if you're also not perseverating on it, because then there's two people perseverating on it, and that's too many. So the absolute basics of masculinizing hormone therapy is to increase the adult male testosterone. This is generally done by using short-acting testosterone esters, usually testosterone cypionate or testosterone enanthate. The dose is typically 50 to 100 milligrams and is given predominantly by a sub-Q route, although can be given by IM, similar pharmacokinetics. And we're aiming for a sort of goal range, target range, that is essentially the adult male range. So in our lab, which is ABRUP, that range is reported as being between 300 and 1,000. I tend to focus on a slightly narrower window of 400 to 700, but the guidelines all say sort of 300 to 1,000. There are other testosterone routes that can be used. The patches aren't available anymore, and the undecoinate is actually under a REMS, so it's hard to prescribe here in the US. But the esters are available by injection, and those with significant needle phobias, there's also gels available. When you think about the monitoring that's needed, during the first year, regardless of whether or not hormones are actually changed, you're going to be monitoring a CBC and a testosterone level every 3 months. If the dose of the hormone was changed, you're definitely going to want to get a testosterone and a CBC 3 months after that dose change. But if, year 2 or year 3, they've been stable on that particular dose of testosterone, I will often only get a CBC every 6 months. I can go into a lot of detail about some interesting things that we're seeing by being here at Elevation in Utah and sort of the interesting effect of erythrocytosis, but we don't really have time for that, so come find me afterward if you want me to totally geek out on you on that. In terms of target ranges, so the guidelines all state that the hematocrit should be kept at less than 50%. But the data that shows harm above 50% is really sparse and is actually based on the polycythemia vera literature. And it was sort of determined that within PV patients, harm sort of occurred, at hematocrits above 55. So they sort of arbitrarily said, well, we should then make the cutoff 50. But that's not evidence-based. So one thing that we're actually hoping to show with some data that we're producing is that having hematocrits that are slightly higher than this are not necessarily putting people at harm's way. And we actually are seeing higher hematocrits, we think likely due to the effect of elevation. The total testosterone, again, between 300 to 1,000, although I like to target 400 to 700. And then in terms of the timing of the blood work, so for injectable medication, you can get peak troughs, although that requires 2 lab draws, which patients don't like. More common is to do a mid-cycle, and so that typically occurs on day 3 or day 4. And then for transdermal, they have to be on the transdermal medication for at least a week, and then you want to get the lab at least 2 hours after the gel was applied. I prefer for them to get it about 6 hours after the gel was applied. And again, talking about that pharmacokinetics, you'll notice that the units here are actually in SI units, so sort of ignore them, but the shape of the curve is what's important. So when you have multi-dose pharmacokinetics, you have the sort of peak that occurs. Generally, that peak is going to happen at day 1 or 2. And then you'll have sort of a mid-cycle that's, again, day 3 or 4. And then, of course, trough occurs on day 7 if you're doing weekly injections, right before they're about to give themselves the testosterone injection. With multi-dose pharmacokinetics, the next time they give themselves the injection, the peak will actually be a little bit higher until they reach steady state, in which point the peak doesn't keep going up anymore. This is one of the reasons why you don't actually check testosterone 2 weeks later or 3 weeks later and are checking 3 months later, because you want them to have reached that steady state multi-dose pharmacokinetics. So this is the injection occurring on day 0, and this is the injection occurring on day 7. And again, I target an injection day 3 or 4. So if they inject on Monday, I want them to get their labs drawn on Thursday. When we think about injection, again, if there's 2 things that you take away from this talk, calm training and then this slide. So choosing the right syringe and needles is so important. Many pharmacies will dispense a 3 cc syringe. If you're using 200 milligrams per ml testosterone cypionate and you are prescribing them 50 milligrams, that is 0.25 mLs. It is not possible for them to administer 0.25 mLs accurately with a 3 cc syringe. Similarly, the 1 cc pop-off syringe will 100% pop off because this is a very, very viscous substance, and it will just essentially become a gel that they are applying topically to their leg, which is not how the injectable is meant to be used. So it is essential that you write in the SIG for the needles that it needs to be a 1 cc Luer-locked syringe. The needles probably don't matter as much, and this can be a problem because, of course, there have been lots of shortages, as we're all aware, and there absolutely are needle and syringe shortages. So one of the other things that I think is important is that when you're starting someone on testosterone, the dose I usually start is 50 milligrams. I'm putting on the SIG discard after 3 doses because they're not going to be able to get 4 doses out of a 1 ml vial because of loss, because of the syringe. So making sure that you're aware of that, because patients will call you saying, I don't have enough in the final injection, and then the pharmacy's like, well, no, this is a controlled substance. They have to get 4 injections out of it. So recognizing that this isn't patients that are abusing this, it's because they're using an 18-gauge draw needle, and they are absolutely losing testosterone every time they draw. So a testosterone-based GOT summary. Increasing testosterone is the primary objective. Aim for a total adult male testosterone to be in the normal cis male range, 300 to 1,000. Use a 1 cc Luer-locked syringe. Sub-Q injections can be better tolerated and have similar pharmacokinetics for IM. This is true for people who you're treating with cisgender men for hypogonadism. And then when you think about the absolute basics of feminizing hormone therapy, it's to lower the adult male testosterone. So again, I sort of stressed this earlier. I think many patients think that it's to get their estrogen level high, but testosterone is the dominant hormone, and it sort of, if there's any testosterone present, it will have those androgenizing effects, and you don't want that. So you have to get that testosterone suppressed. The other thing that patients may not realize is that estrogen is the primary suppressor of testosterone, and it goes back to that graph I showed you where sex steroids negatively impact the anterior-pituitary and the hypothalamus, resulting in decreased production of GnRH and LH and FSH, which then decreases testosterone production. The problem is that in order to have estrogen suppress testosterone, you have to use high doses of estrogen, and we know that estrogen is what confers the most most risk. So this is why this type of therapy actually involves the use of anti-androgens as adjuncts to estrogen so that you don't have to use high doses of estrogen to achieve these effects. In the United States, we primarily use spironolactone and GnRH agonists. In Europe, they use another drug called cyproterone acetate, which is not available in the United States. But again, this graph sort of explains why estrogen is the sort of primary way in which testosterone is inhibited. There's multiple different types of estrogen, so oral and sublingual. There's also transdermal patches, and then there's injectable. For anti-androgens, again, we primarily use spironolactone, so that's really the only one I'm covering. When we think about monitoring in these patients, they need a baseline potassium, and then potassium, estradiol, and estrogen need to be monitored every 3 months during the first year. The potassium monitoring is also something we're really interested in. The derm literature has shown that young, healthy people do not develop hyperkalemia from spironolactone, and so dermatologists have by and large stopped checking Spiro for people on have stopped checking K for people on Spiro under the age of 45. So we're actually trying to sort of show the same thing in young transgender folks as well. But you do need to monitor the testosterone and the estradiol. And then anytime the dose is changed, you need to be monitoring those things. And then, of course, you can get other labs as needed. Potassium level ideally is less than 5. Estradiol desired range is 100 to 200. And then that testosterone less than 50. That's what your target really is. In terms of blood work, sometimes with an oral you can get an AM trough. Oftentimes with oral sublingual, they'll dose it twice daily. That often is because the drug can cause some nausea if given all at once. In individuals who are using BID dosing, I actually like for them to get their labs drawn about 6 hours later, because that's almost a peak with the oral administration. But if you're getting an AM level, that's primarily a trough. And so just know that that's what you're getting, and interpret the labs accordingly. For injectables, just like with testosterone, I like for my patients to do the mid-cycle, although super therapeutic levels are more common with injectable estradiol, and so oftentimes it is necessary to do both peak-trough analysis to make sure that you're not actually getting people into sort of the upper stratosphere, which can often happen with injectable estradiol. And again, the pharmacokinetics of this are really interesting. So this is a paper, I think, done in 2021 by Dahl. This is transgender women who were given both sublingual and oral estradiol. So the sublingual is the darker, and showing that really high peak at around 1 hour, and then eventually coming down and sort of exhibiting similar pharmacokinetics by 6 hours or 8 hours. But you can imagine that if someone is taking their estradiol sublingually and they get their labs an hour later, that is going to impact how you are interpreting those compared to if they got it, say, 6 hours later. So knowing when the labs were drawn in relationship to when the hormone was given is super important. So again, a summary for estradiol-based hormone therapy: lowering the testosterone is the primary objective. Estradiol is the main anti-androgen. Using adjunctive anti-androgens allows you to use less estradiol, and that estradiol likely confers the most risk, and it is easy to get stuck in the weeds with the labs, and don't go chasing numbers necessarily. So a summary of all of this: creating infrastructure makes it easier for providers, especially learners, to offer gender-affirming services. New patients may require multiple visits in order to obtain the appropriate history and discuss the appropriate pros and cons, risks and benefits, and goals and timelines. Visits and labs should occur every 3 months during the first year, anytime the hormones are changed, and then generally 1 to 2 times per year indefinitely while people are taking hormones. That for testosterone, the goal is 300 to 1,000, or again, 400 to 700, and that you can use IM or sub-Q. Sub-Q has similar pharmacokinetics and is generally better tolerated because it's a smaller gauge needle. And definitely that 1 cc syringe, super important. And then for estradiol, testosterone less than 50 is the goal, and the estradiol goal is between 100 and 200, and you can use PO, sublingual, transdermal, and intramuscular routes for estradiol. So finally, I would just like to urge you to kind of keep calm and say yes to your patients, even if it's not yes, I will provide you hormones. It's yes, I will treat you as a person, and yes, I will see you for who you are. And yes, I will help you get connected with someone who can help you with this. And whether you're dipping your toe or sort of wading into the water or fully prepared to dive headfirst into this, I want to acknowledge that you will have roadblocks, and you can always contact me if you have any questions. So I've put my email address at the bottom, and I will absolutely give you my cell phone number, and you can text me anytime if you're running into questions or concerns, because I want to help prepare the healthcare workforce to do this, because there's only one of me, and I want it really to be all of us who are providing this care. A few more resources for you. So we actually recently just wrote it's more of a commentary in family medicine, sort of a call to action for transgender care. And then I actually recently gave a TEDx Salt Lake City talk, which is totally bonkers, and it's going to be released on TED.com, which is, again, totally bonkers. So it's not out yet, so if you go here, you'll be like, it's not here, it's not there. So stay tuned, but it will be coming out soon. Other resources, like I said, this National LGBTQ Health Education Center is a fantastic resource. It has so much. So if this is something that you're interested in, please connect with this. The UCSF guidelines are amazing. They're very comprehensive, although they haven't been updated for a while. But they're really orchestrated and organized in a way that's very approachable. The Journal of Clinical and Endocrinology and Metabolism has the Endocrine Society guidelines. These are actually also undergoing review and should be updated recently. And then just pointing out that if this is something you're interested in, next year, Mountain West Transforming Care Conference is going to be held in Zion National Park. It's between May 8th and the 10th in 2025. And again, this is the conference for which I'm the medical director. And then the WPATH always has GEI conferences. There's one coming up at the end of May, and then there's actually the World Professional Association of Transgender Health Conference that's occurring in Portugal this year in September. So if you're interested in some international travel and want to, really dive into this, that's a great place to go. And then finally, I think sometimes people expect me to sort of say the reason why we should all be doing this care is because it's the right thing to do and because these patients deserve, culturally competent, evidence-based care, and that's true. They absolutely do. But that's not the plug that I'm going to make. The plug that I'm going to make is that medicine is hard. Treating poverty with metformin has a toll on you. And asking patients to change when they don't want to can really be hard to do day in and day out. And embracing this with your patients and going on this journey with patients can have a transformative effect on your own experience as being a provider, because suddenly, your patients just are, all they want is change, and you're finally being a part of that, and it's so powerful. So remember, first, do no harm, and doing nothing is harm. Thank you. And I'm sure you guys are really done, so if you don't have any questions, that's okay. I know you've been sitting in those chairs for a long time.
Well, I do. Can I?
Absolutely, yeah.
Can I also say something?
Sure.
I just wanted to thank you for the work that you do. I think it's so important, and definitely my patients have been negatively impacted by some of the discrimination. I'm an internal medicine doctor, so I see old patients, and I think maybe the UCSF source is the answer, but one of the questions I have is my patients who are on hormone replacement therapy who have various organs, who needs mammography, who needs prostate cancer screening? Not that anybody does. Cancer screening is kind of my question. Is there a good source for that?
Yeah, so I think the UCSF guidelines are a great place to start with that. Understanding, though, that the last time that was updated was in 2016, and actually the American College of Radiology has put out some transgender-specific guidelines, and so, understanding that, there's other things out there. As it relates to cancer screening, I often say to patients, ask 5 doctors get 6 answers about whether or not, screening, what age, what time, and things like that. Here's the sort of quick and dirty, though. For transgender women who are taking hormone therapy, the recommended age is starting at age 50, and they have to have been on hormones for at least 5 years. For people who are taking testosterone-based therapy, it is essentially the same as cis women, as long as they have not had top surgery. Because, of course, if they've had top surgery, there's no breasts there, and you can't do it. Prostate cancer, I am not even touching that with a 10-foot pole because that's super controversial. Obviously, it depends on who you ask, right?
Yeah.
Generally, within my clinical space, that's having a conversation with patients about the pros and cons and risks and benefits of PSA screening. But recognize that these drugs can affect the PSA. Some of the drugs that are used in gender-affirming care can do that, and that for individuals who undergo vaginoplasty or vulvoplasty, the prostate remains.
Okay.
And so talking with patients about how you still have a prostate, so we might need to be thinking about screening this. Colon cancer screening, no change. Pap smear screening, if you have a cervix, you need a pap smear.
Thank you so much.
Yeah, you're welcome.
Hey, thanks for coming to the conference.
Thanks
First
for
off, having me. You bet. Does UCSF have a hotline? I saw you said ask for your phone number. I don't want to do that, but is there a hotline that clinicians can access?
No, but there are a couple of different organizations that do echoes. So not quite the same, but there are some organizations that do echoes.
Great. And the other question I had, your talk is really geared towards the younger patient who's transitioning. I know everybody's leaving, but do you have 2 minutes to talk about middle age or elderly, or maybe someone who was young and has moved on to those? I mean, do you continue treatment? Do you start treatment later in life?
Yeah, so I would actually argue that the talk was geared towards adults because I didn't mention at all puberty blockers, right? And that's really the main part that sort of differs with adolescents. Yeah. I would say that the average age of people who are starting hormones in my practice is about 30 or 27 to 30. Yeah, that's true. That's fair. What we don't know is what should happen as people age. Should people undergo a transgender menopause? Should transgender men undergo some sort of andropause? Should we adjust the level of hormones down as people age? And then, of course, as new chronic conditions occur, we need to be sort of interplaying the hormones with that. And so when we think about transgender medicine is sort of a newer area, that is one particular part of it where there is just a paucity of information. And every time I go to conferences that look at this, the session that's on aging transgender people, overflowing people in the hallway, because this is the thing we all want to know because we don't have answers. In my practice, generally what I would say is as people get older, I am more inclined to put them on patches for estrogen because the patch seems to confer less venothromboembolic risk, and as we get older, our risk of venothromboembolic disease increases. So that would be the one shift that I make, but I am not necessarily targeting different hormone levels in those people. And what about someone who actually comes to me at 65, right, rather than 35? Am I sort of targeting different things? I'm really not, but I am having conversations with them about what reasonable expectations of change are, because I think the earlier that you start hormones, the more likely the physiologic outside is going to match the inside, whereas when people start quite a bit later, I think it's unlikely for them to see the same changes that someone who started at 21 is going to see. Thank you.